All right, so we'll finish up. So yes, I know today 1:30 is the time. We're not going that extra half an hour thing confusion that we had last time, so that's why we're gonna finish up the head injury stuff. Okay, so when it comes to head injuries, some of the early signs, early presentations. Which one do you think you're gonna see first out of these?
Altered LOC.
Nope.
Confusion.
Nope.
Headache.
Nope.
Restlessness.
Restlessness. Restlessness is one of the first ones you're gonna see. People can't hold still, right? Because like they just start to get a little agitated. They're moving. They're constantly on the move. You're like, dude, come on, sit down so we can check you out. Hold on, let's just sit here for a second. That's gonna be one of the first things that you're gonna start to notice.
Like methy type restlessness?
Yeah, like,
Almost like
can you
like
show
you're
us
not
restlessness?
you're not quite like full meth style.
Chris on two bangs.
But you're constantly just like you go to get a blood pressure on somebody and they're just kind of like what's going on kind of thing, like because they're not totally comprehending a lot of like kind of like that concussion style thing where they're got a little bit of a slight confusion but they don't realize that they're confused, so they're just constantly just second guessing everything and they're just like almost like a paranoid, not full meth style but close.
Half that style.
So can you have seizures from ICP? Is that the question?
I know that is true, but will you see, well, I guess that's a stupid question. Because you're gonna have those signs and symptoms anyways. My question was, could you have ICP from seizures?
From seizures. I mean, I'm sure you would get some potential increase in ICP, but then what happens once the seizure stops? Everything kind of goes back to normal, so it would reduce, right? So it wouldn't be a long-term presentation, whereas with actual ICP secondary to a head injury, head trauma, you have your edema, which then is what's causing it, right? So you're gonna get your restlessness and confusion developed by a headache, okay? Developed with a headache. Late signs are altered LOC, unless it was a significant ICP, significant injury where it progressed very quickly and very fast. Pupillary dysfunction. What kind of stuff are you going to see with somebody with a head injury?
Unequal people.
Sluggish is going to be your first presentation, so they're going to be delayed in the response. And then if you end up with significant unilateral ICP, you're going to get unilateral dilation, constriction. This is where your unequal pupils start to present themselves. Are unequal pupils bad?
Yes.
Are they bad all the time?
No.
Do
With
some people have
ICP.
normal unequal pupils?
Baseline unequal pupils,
Because
yeah.
their eyeballs
Yeah,
screwed up.
I mean they can have underlying conditions that have unequal pupils. So anytime that you have somebody with those types of things and their mentation is still normal enough that they can answer questions, you want to make sure that you clarify whether or not those pupils are normal or not, right? One of the scenarios that we do for probationers, one of our training people will take atropine and put a drop of atropine in one of their eyes to cause one eye to dilate out, and then they go into this. I mean, they're dedicated for scenario stuff, right? Like me, I'm not dropping atropine in my eye. Okay, just so you guys know, if my pupils are ever unequal, that means that there's something wrong with me. Okay, but like legitimately, like it's this stroke, trauma, seizure person all at once, and so they have unequal pupils, so you can legitimately check his pupils and see, hey, these pupils are unequal, and so it's kind of a shock that first time you actually see like somebody that's is actually normal, but their pupils are all unequal. So then it'll catch you off guard sometimes where you're just like, oh, hey, is this normal for you?
Cindy has super unequal pupils.
Does she?
Yeah.
Yeah.
Oh, see, there
That's
you go.
from surgery.
Because she got part of her iris taken out.
Yeah.
Those are
But
cool
they're,
to see
it's
though.
cool to look at.
So she just looks like she is
Are they
two.
still round?
No.
No, one's
Ah,
a
see.
teardrop, and then in that same eye, there's a corner of the iris that's taken out. So it kind of looks like she has two pupils.
Okay, so next time you guys see her, don't tell her that's what you're looking at, but get right up close and just stare at her eyes.
Oh, she'll test you. Yeah, that's the thing for the basics when we taught him how to do.
How to check it, pupils and stuff.
Yeah, she was the one we had him check on in half of the class.
Called Pearl.
Yeah, well, all of them called it, but only half of them noticed that she had something wrong in her eye.
Yeah. So anytime meet people, have situations like that. It's cool to take a look at them, because like, some of them are round, some of them are like the teardrops, some of them are kind of like an oval looking shape. And so just getting to know kind of what's normal and what's not and how they look is pretty cool.
How long does that atropine last?
So usually, I would say it probably lasts about 2 to 3 hours. Like, I don't know what they use at the eye doctor to dilate your eyes. Yeah, but it seems to last about that same duration. Because he'll go all day doing scenarios all day, and at lunchtime he'll have to put new drops in. So. All right, headache and vomiting. All right, anybody that has got hit in the head that starts presenting with headache and vomiting that does not have underlying migraine headaches is a bad sign. Okay, so that means you're progressing. If they get to the point where they're having difficulty speaking, has anybody ever gone on a stroke patient that seems to be like they're talking with you, but they're really struggling with the words that they're trying to come up with, and they appear to start to get frustrated? Like, one of the best things you can do, best ways to talk to them is like, so I see that you're struggling and you're getting frustrated. Are the words coming out of your mouth not the words that you're thinking about? Are you having a hard time getting the words from your brain to your mouth? And don't ask them to say yes or no. Just ask them to nod yes or no, right? Because they can still function that way, and they can communicate. The other thing you can do is you can communicate with like 1, 2, 3, 4, 5. Give them options on your hands. They can choose between that. They're totally clear there. They just can't get it from here to here, right? And so getting those clarifications on where they are in that process is going to help you out. Yeah.
I actually experienced that with migraines.
Like you develop?
The words in my mind and the words coming out of my mouth are two separate things. And I just ran into a friend who has the exact same problem. In fact, he thought he was having a stroke this weekend.
So you realize you're talking about hamburgers and bacon and sausage right now,
No,
right?
I can tell when it's
Oh, okay.
because I can hear the words coming out of my mouth and I'm like, those are not the ones I'm saying.
Okay, cool. So it's a pretty interesting, it is a frustration, right? How long does it last?
For me, it can be like anywhere from a half an hour to an hour.
Okay.
And it's bad. In fact, the first time I had it, I thought I was having a stroke.
And that's, as a pre-hospital care provider, are you thinking he's having a stroke?
Yes.
Yep.
Absolutely, right? Because what do we think?
Worst case scenario.
Worst case scenario first, right? He's presented with a headache, he's presenting with aphasia, or dysphagia, and like, okay, you're gonna do your full neuro assessment on him, right? What happens if he comes back with everything else is working fine?
You're still gonna.
Still stroke.
Is he still presenting like a stroke?
Yeah.
Absolutely, right? And so, James is now a code 3 transport to Riverbend, okay, because you got a headache. All right? Changes in respiratory pattern. What are we looking for?
Shane Stokes.
What do we start with usually?
High respiratory rate.
High respiratory rate, and what
Deep.
type of high respiratory rate?
Shallow.
And in a brain / traumatic injury, what kind of, it's not really shallow, what type of breathing rate starts off when we have neurological effects?
Slow them fast.
No, Shane Stokes are the late.
Are they
Fast and deep.
variable?
Fast and deep, also known as,
Too small.
huh?
Too small.
Kussmaul. If you flip it out of diabetic ketoacidosis, it's not called Kussmaul's, it's called
Cushing's triad.
Cushing's triad, then grabs onto Shane Stokes. We're not quite there yet. Central neurogenic
Can we draw these
hyperventilation.
breathing patterns just to make sure we're all thinking the same thing?
What's that?
Can we draw the breathing?
Yeah. Yeah,
To make
so
sure we can think?
Kussmaul's, right? We all remember Kussmaul's, central neuro, all right. Kussmaul's is for your DKA, it's like VTAC, right? It's like very regular, very deep, very pattern oriented. Central neurogenic hyperventilation looks like exactly the same, okay? It just has a different cause, right? Now our neurological cause to start things off. Shane Stokes. Shane Stokes is
Torsades.
For the lungs.
it's not quite torsades, but it's very similar to torsades. Because you have periods of apnea that will be thrown in as well. With torsades, you got slow, fast, slow, fast, slow, fast. But with Shane Stokes, you're very common to get periods of apnea in there.
For the Shane Stokes, is it all fast, or is it fast and shallow, and then deep and slow, and?
Yes, very erratic. It's very erratic is the Shane Stokes. Your central neurogenic hyperventilation is deep and regular. It's an early sign, okay? Kuzmal, central neurogenic hyperventilation are exactly the same pattern, just different causes.
And so Shane Stokes is late ICP.
Late ICP, and that is part of your Cushing's triad.
Early ICP is what was it called? Neurogenic
Central
central.
neurogenic hyperventilation. Yeah,
And you're gonna be able to tell Shane Stokes from agonal because they won't have the super fast little
correct.
ones?
Yeah, so agonal is just
Oh, really?
Right.
I thought agonal was like nothing and then
eventually.
and then nothing.
Eventually, right? So you can watch the pattern so slower and slower and slower to the point where you're like, hey, we're asystole, we've been asystole for a while. You pull everything, you call it, and all of a sudden something will go, and you're like, oh, jeez. And so what does family members do when they see that?
You're alive.
They're alive! Do something! And we're like, oh, jeez. Oh, jeez. So do we walk over and hook the monitor back up?
You push some morphine.
Yeah.
We do. We go double check, right? You don't want to be that crew that has to respond to the morgue to, hey, we got a live one! Don't know what to do!
Has that happened?
Have you ever had that?
Me, no.
Has it
Have I
happened?
laid in bed late at night, though? Laying there going, I can't go to sleep. Yep, that person had a idioventricular at like maybe 10 beats, like every 5 minutes kind of thing. But I was like, well, there's still a beat there. There was no pulse. It was PEA. Oh God, please help that epi doesn't ever kick in. oh geez, I was almost asleep. Oh, man. I know we're gonna get a call. I know we're gonna go. So no, there are calls where we called it, and oh man, you're just not 100% comfortable calling it. I mean, you're comfortable calling it, but you always have that, because you've heard of people waking up in the morgue. People legitimately have woke up in the morgue, not locally. These are like maybe like 1 or 2 every couple years in like faraway countries, not the United States.
I see it in the movies all the time.
Right? Yeah. And so, no, it has never happened to me. I've only had one call where the cops called us back and says, hey, this person's breathing. And we went and we checked and we're like, no, they're not breathing. And they're like, okay, maybe it was just our imagination. And then the person goes, I say, oh, yeah, that's normal. That's normal. Just keep the blanket over on. If you just look away long enough, set the pillow on top of them, plastic bag, get them in the more plastic bag kind of thing. So those are the nerve-wracking, those are the nervous ones. Like, you really panic when they say, return back to the scene, on one that you called.
It's almost like those guys are ring kill.
Oh, please be a family member that you need to assess, right? Because we'll go back frequently for family members. They're in the back of your mind, you're like, yep, this person that you pronounce is now sitting up talking. Awesome, you had a bad day. Yeah.
So for Shane Stokes, are they
Yes.
actually moving air?
Yes. Yeah.
So for agonal, they're not really moving air.
So
They're
they-
just kind of
So,
jogging around.
so with agonal respirations, they can potentially still be moving air. So that's where, depending on where you are in that cycle, if you're at the end cycle where basically they are doing the gas
Yeah.
thing, that is your late sign, that is they're not moving air. But early on, so if you have basically like a Brady, how would you say Brady apnea?
Bradipenia?
Bradipenia.
Yeah. So if they're breathing very, very slow, like 2 or 3 times a minute, they can still be agonal and they still can be moving air. They are in the process of transitioning to non, yeah.
And for pediatrics, you are not gonna ever, you're unlikely to see agonal respirations on a ped because the cause of their code is usually respiratory.
Most of the time they are respiratory related, yes. But if they have underlying cardiac conditions when they're born, you could end up presenting with that. They
You
have
could
ac-
still see
Yeah,
that.
you could still see agonal respirations. But most of the time they are respiratory in origination.
Will you see on little babies, even though they're obligatory nose breathers,
But we see what?
agonal or Cheyne-Stokes respirations on an infant because they have to breathe through their nose?
Not usually. Usually, so if you have a head injury, ICP, which we'll talk about here at the end, so pediatrics present a little bit differently because with their, can pediatrics get ICP as easily as adults?
No, because they're.
No,
No,
they have,
So the
they have
answer
the
is no.
fontanelles.
And why?
The fontanelles is not pediatric, that's like,
So
Infants.
they have not fused, right? Their skull is not fused completely yet,
Yeah.
so they have soft spots. So that allows for more expansion of the brain. So it allows for more swelling prior to getting that ICP presentation. So it's going to be very, very late sign. It's going to be a very short period of time. And by the time somebody recognizes that there's something going on, then it's going to take you minutes to get there. You're probably not even going to see any of the transition going from hyperventilation to Cheyne-Stokes. They're going to be super sick, and you're not going to probably get even the hypertension. They're probably going to be already on their way back down. Because it's
what about
such a fast
kids,
transition. It's a bad
whose,
day.
whose schools, like, don't have fontanelles?
Yeah, don't they?
Oh, are you fused?
Yeah, I mean, what
So,
about?
so an older presentation, then you're going to end up getting some of the presentation
Okay.
of that. Sorry, I was thinking more along the lines of the
Infants.
non-infants, because those are a lot of times where you'll get like the suspected abuse kind of things where,
Oh, yeah.
like, hey, you think you're going on a SIDS death, but then there's a lot of stuff that's you're just like, wait a second, there's a lot of question marks around the story, around who's here, around the signs, and so that's where a lot of times you'll see very, very late, like, why is this kid bradycardic? It's like, oh, this is weird, but it's like past that point of normal bradycardia where we're into cardiac arrest bradycardia kind of thing, because it's a very late sign that we've gotten there. Okay. So vital signs. Initial presentation with a head injury. We're gonna be what? Prior to ICP.
High heart rate.
Increased heart rate. Yeah. Respiratory pattern is gonna start off pretty fast. What's our blood pressure gonna do?
Jump.
Is it gonna be normal to start off
It's
with?
gonna widen.
Okay. And as, let's see if we got it, it's the next one. Okay, so we got a couple. All right. So carbon dioxide is gonna play a huge role in how our body reacts, right? So, so you end up with cerebral vasodilation, right? So let's go to this. Here we go. So you got your cranial insult.
You don't have to go
You end up with your tissue edema, right? So once you have your tissue edema, it's going to cause increased intracranial pressure, which presses down the arteries. which
It's
decreases
brain
blood
tissue
flow.
edema, correct?
Brain tissue edema, correct,
you.
yes. Non-vessel stuff, yeah. Okay? So then you're going to get compression of the arteries. Now we're affecting our vessels, all right? Which is going to decrease cerebral blood flow, leads to low O2, death of the cells. Boom. Now we're going to start getting edema around the necrotic tissue, which is going to increase your ICP around your brain stem, affects your respiratory center, and this is where we're going to start to get our transition. Okay? So now we get our transition, and then now our CO2 starts to accumulate. Why is our CO2 accumulating? Because we were hyperventilating, right? So we were blowing it all off. Now we're moved on, we're into Cheyne-Stokes, so now we're starting to retain some of that more, right?
So that CO2 accumulation, is that when we're hyperventilating, our end tidal is gonna be low, is that correct?
Right.
For your
And
respiratory.
so then, once you get to here, once you start affecting your respiratory pattern, we move over into the Shane-Stokes now. So we went from trying to regulate up here, we're hyperventilating up here, trying to regulate, okay? And now we're
That's-
affecting our pattern now. So we're transitioning into Shane-Stokes. Shane-Stokes is now gonna cause our CO2 to increase because we're no longer hyperventilating to blow it off, okay? So it accumulates, increased ICP due to low blood volume equals,
Is that when like it swells so much that it's forcing the brainstem through the foramen magnum or whatever?
yep, or it doesn't have to push it through the foramen magnum, it could just be pushing it into the back of the skull, to the base of the skull. But yes, that is the same concept associated with that.
That's a
Chad,
lot.
yes?
Is the transition between biots and Shane-Stokes like instantaneous?
Nothing's ever really instantaneous. And so when you say biots, are you leaning towards the hyperventilation? Yeah, no, so it's not gonna be an instantaneous thing. So these patterns here are gonna be your hyperventilation portion of it. You're gonna get these little hyperventilations. And so they're just gonna start getting shorter and shorter, okay? So you're gonna get patterns where they're going fast, and then all of a sudden they're just, oh, hey, here's a couple short, weird, erratic ones. And then, oh, we're back to our hyperventilation a little bit, and then, oh, here's a couple more. And you're gonna get further and further, and these are gonna get shorter and shorter. And then that's when, the more you do it, the more periods of apnea you're gonna get. So the shorter the hyperventilation occurs, the more apnea moments you're gonna get. And eventually, you're just gonna end up with a couple short breaths and then apnea. Hold on, there's one other over here. Yeah,
Is it worth giving bicarb to someone in Shane-Stokes, or not really, because you're just treating a symptom?
you're just reading this second.
I don't understand the increased blood volume, like why is the blood volume increasing?
Because you're getting vasodilation, okay? So your blood vessels normally are constricted, right? And so that's gonna reduce blood flow. And so when you vasodilate, you're making every attempt to flush, and so all that blood is trying to get itself there. So up here, you're compressing the arteries, right? So as you compress them, as you open those up, they're trying to get as much blood through. And so as you transition to over here, so you're getting the edema over here, and then when this starts to accumulate, CO2 causes that vasodilation, which is then gonna cause the increase in blood.
And that's just in the brain?
Yes, and I was gonna say, and so that's in your compartment that you have there. So basically, it's opening, relaxing those blood vessels in an attempt to fill up with the blood.
Will those vessels be able to dilate if there's a compression from the edema?
So that's where some of your respiratory pattern is making the attempt to try and vasodilate and constrict in order to increase and decrease the oxygen demand. And so depending on where the edema is, like, so you may just be edemic in one area, where the rest of the brain will make an attempt to vasodilate and create blood because part of the brain is not being oxygenated. So other parts of your brain will vasodilate, which then puts pressure on the rest of the brain. Because you gotta remember, you're all in like one compartment. And so if nothing's happening here, all these vessels open up, it's still gonna put pressure on that stuff because the fact that you have the compression, you're not gonna get good circulation with your venous and artery returns. So basically everything's stuck there in your compartment. And so if you just open everything up, that's where you're gonna end up in that compartment having increased pressure. Okay? Alright, okay. Alright, so, herniation of the brainstem. We talked about vomiting, altered mental station, those are the two big ones that we're gonna recognize. Vomiting is projectile vomiting, non-warning vomiting is bad. Like, if you'll be sitting there and somebody had a head injury and they'll just be talking to you, and they won't have the nausea beforehand, it's an instantaneous face full of vomit is what you're gonna get. So that's why we wear our eye protection at all times. Like you get maybe like a slight cough slightly beforehand, like, and then right out it comes. There's no warning, there's nothing, it is just vomiting instantaneous. And it is not a small amount of vomit usually. Usually it's everything that they have in their gastric contents, in their entire GI tract. I swear, I don't know how they get it out of their bowels, but everything from there comes out the mouth. Like, it is everywhere.
Does that ever happen to you?
Do you think I'm just like randomly just make something up? Like, that's why, I mean, I even gave you the little tip of the trade that most people don't know, the right beforehand moment.
So in other words, whenever we see that, just.
Like,
Duncan Covey.
so,
Heavy partner book.
so the funny thing, over there. So, okay, so normally, right? So normally you got the patient sitting on the gurney, right? And I knew that, I may or may not have known that this person was sick. I didn't know they were sick, right? And I suspected that, hey, you got your bell ring pretty hard, right? So, gurney's here, you all sit here, right? Well, I had a paramedic student with me who was in the CPR seat, right? And so, may or may not have done one of these, the little cough, and I see it coming, and I grab the face, and I push the face.
Oh, right.
Right at the paramedic seat. I'll be totally honest. And so it got all over their pants. They did one of these, like, full-on meltdown, like, ah, kind of things. And then a little bit of me laughed. And then I was just like, oh, my bad, that's poor form. I looked around and I'm like,
I'm good.
I'm good.
I'm good. Totally clean. But yeah, so no, you get that little, it's like a cough / hiccup moment just before. Yeah, Gene. Oh, it's not really a. It's something that until you see it, you won't really know what it is. It's like the mix of a cough and a hiccup together, and it has you have like less than a second, and then here comes everything. So.
Did you have that listed under brainstem injuries? Is that only time you'll see it, or pretty much any time? Upper brainstem vomiting?
So a lot of times that's an early sign. So once they've gotten to that point, so they're unconscious now and stuff, a lot of times they can become like a volcano, where it's not necessarily a large explosion, but it's a continuous just vomit just coming out. So that's why managing brain injury patients with the ET tube is really, really important versus going with the king. Like, I despise king tubes already. I despise combi tubes. I am a huge ET tube person because it completely controls your airway. Yeah, kings are nice when you have struggles. The only reason that people struggle is poor form. That's just my personal opinion. And I tell people that all the time. It drives me crazy when people drop kings after one attempt at a ET tube. And so, has everybody been in the OR? No.
Until March.
Has anybody had a tough tube in the OR yet?
Yeah.
There's never
I had a tough
tube.
one in the ER.
That was a total setup, dude.
So, well, it took the doctor 8 tries after me, and we almost cranked it. So.
Why was it tough?
He was just really anterior.
Of
He had
course,
a
anterior.
lot of swelling. They thought he might have been on some kind of radiation therapy. So he had like really swollen glands. And so like I went in and I was like, oh boy.
Yes, I know those moments where you get in there and you're like, oh shit.
Yeah, so I tried and I missed, but then the doctor tried a whole bunch and they ended up using a bougie to get the bougie into the trachea.
Everybody remember the bougie?
Yeah.
Coming from the trachea
Getting
up.
a lot more smaller, a little bit easier to manipulate. Those are perfect for those swelling things. Okay, I'll give you a tough tube on the swelling. I'll give you that. Allie, yours better have swelling involved.
No,
Or anaphylaxis,
No.
or burn,
No.
or
It was in the OR,
trauma.
so it was a pretty
Oh.
controlled, but because I placed it wrong, I knew I had placed it
Right,
wrong.
that usually happens.
But the doctor wanted me to continue to ventilate while it was in the wrong place to see what not to look at, or what you wouldn't see, which was actually
Hey,
kind of cool.
Hey, for the record, if I am in the OR and you guys come in to intubate me, don't put fill my belly up.
So we did it for a few breaths, and he was telling me kind of what to look for and everything. He's like, okay, now inflate it and put it into the right spot. You have one chance. Or
Yeah,
else I'm
so
having
why
the
would we
next
not ventilate in the pre-hospital setting versus the OR? Why would we not ventilate the,
You don't have O2
Yeah.
field.
what, everybody goes in for surgery is what? NPO, right?
Yeah.
Like, they haven't been eating for 12 hours. Who do we go on? Beer and
The
pizza,
person, yeah.
Working on it.
right? So you put air in somebody's belly that has beer and pizza in there, you're basically like pressurizing.
It's
You're
a
like
free
shaking-
meal.
You're shaking the bottle, you're shaking the bottle, you're shaking the beer bottle in there. You're
Pull the
like,
pin.
let's just put some pressure in there, mix it up, and then you pull the tube out and pop goes, yeah. You don't even need ICP.
That's what I was
to
gonna
get
do, and
projectile.
then he like took the syringe that I was about to deflate it with, and he's like, no, you can't deflate it yet, you have to ventilate with it in the wrong
Because you
place.
screwed up,
Yeah.
because you took the goose.
Tube the goose.
That's what we call it when you put it in the esophagus, you took the goose.
I got it after that.
Yeah, okay. Was there somebody else that had a tough
I
one?
missed one, but we changed techniques and they.
And what technique did you, what was it,
Well, he first gave me I first used a Mac without a stylet, and then, cause he can't, that's what he handed me with, and he's like, I never used a stylet, so you don't get to use one either.
Oh. What did we say
And
about
then he-
stylet early on?
You don't need one.
No, you absolutely need one, because you always want to have every successful tool to
Yeah.
make it successful the first try, right?
Yeah.
You don't wanna have to do a second time.
So he goes, change something, and I go, cool, give me a stylet, and then I missed it again. And then, he was really
Killing me
interior,
here. Killing
and
me
then we
here.
went to a Miller, and that picked everything up a little better, so he had a better angle.
So, when you use the Mac, did you use the Mac like a Mac, or did you use the Mac like a Miller?
I used a Mac like a Miller.
And you still missed?
Yeah.
I got nothing for you then.
I'm learning, it's still new.
Okay, so, with innovations and stuff, technique, knowing what you're looking for, knowing anatomy. I know I talked to you guys about using your right hand to feel the trachea. A lot of times you can feel the trachea with the right hand, left hand with your laryngoscope, and you can tell where you're at. Like, you can go in there without even having to do an innovation.
She's like chowing down on my trail mix. I'm like, oh, have some trail mix. She's like eating the whole thing.
She's nervous, it's the nervous snacking.
Yeah.
Alright? And so, yeah, so just technique. You do not want that vomit ending up all over everything, right? Because what is vomit going to do if it gets in the airway region with a king tube? So yes, the king has a great idea of it has a little bit of a cuff there, right? Does that seal 100%?
No.
No. You're still going to end up with the potential for aspiration. Is aspiration going to have a decrease in recovery ability?
Yeah.
Aspiration pneumonia, right? Sick people. All right. Amnesia, we've talked about all that.
We talked about amnesia?
Oh, did we not talk about that? Oh, I must have been talking with my probate about this. Funny story. Oh, this is a good one. So my old engineer, coolest guy in the world, right? He's a no-show for work one day. And we're like, what is going on with this guy? Like, what? We don't even know. This guy's always super early. He's just a full no-show. Lives out in the Thurston area. So we start calling around, trying to track him down. And we're like, dude, where is this guy? Nothing. Nobody can get a hold of him. Luckily, the guy can hold over. Next thing you know, this dude rolls in like hour and 15 minutes to an hour and a half late. And he is covered in scratches and blackberries, and like, he looks like he just got beat up. And we're like, what is going on? Right? And so we're trying to figure this out, and this guy is super confused. But he's just like, I'm ready to work. And we're like, no, you're not. Something's up. So we start talking to him, and he's just like, yeah. I'm here to work. I rode my bike to work. And we're like, we walk out and we look at his bike and both tires are flat on his bicycle. And he lives in Thurston. And this was out at Station 10.
That's hardcore.
Yeah.
Right? And so that's like, we're like, okay, none of this is making sense. Right? And so we're like, so we call his wife, who was at work. So she goes home, finds his car, like halfway out of the garage, like in their front yard, with two left side flat tires, and the whole left side of his car like totally, like it had been run up against the guardrail. And then you just see these giant tracks in his front yard. And she's like, is he okay? And we're like, we don't really know right now, right? So he doesn't remember anything, right? So he has no idea what's going on. So the funny thing, to start this all off is he had taken Ambien the night before for the first time. So he takes Ambien, right?
How?
So we tracked everything, and based on all the history of events, so we ended up taking him to the ER, having him evaluated. And so it sounds like what happened is there was a thing on his cabinet where it looked like he had hit his head on the cabinet on the way out to get in the car to go to work. So he had hit his head on the way out, gets in the car, still didn't really realize what had happened, and somehow starts driving around the neighborhood not knowing where he's going. And he's just driving around in a circle. He ends up hitting multiple curbs, and you can see right where they just gouged, like, take full chunks of concrete out of the curb. And so, like, his tires are flat. Somehow, he manages to make it back to his house and park there. And he has enough, like, thought to be like, I gotta get to work. So he takes his bicycle, and somehow, he doesn't remember exactly how he got from point A to point B. He says he remembered being over an embankment at one point with his bicycle, carrying it up the hill. That's the only thing he remembered from Thurston to Bailey Hill.
That's such a long way.
And he's only an hour and 15 minutes late?
And he's only, right, and because he's always super early, and so, like, he was usually like an hour early, so we're like, man, this is like, so nothing was like making
2
sense
hours
at all. And so, yeah, so we don't even know how he got from point A to point B, but when he got there, he had a giant goose egg on his head. And so we're like, dude, like, were you hit by a car or something on your way here? And then the wife starts telling her side of the story, and yeah, so basically the dude got his bell rang. So he was a little confused from the Ambien. He was still super groggy, and so as he was like doing this like walking thing to the car, because he doesn't even remember if he was awake walking to the car, because it was weird because he had shorts and flip flops on. That's all he had on to start with. And so yeah, because they found his shirt in the car, like off. Like, it was bizarre. This crazy bizarre stuff. So this guy, like, he has no recollection except for little bits and pieces of the event leading up to it. And so they called it like that he had a concussion, but they called it like transient acute amnesia. And so to this day, like, we're like, hey, dude, remember that time you didn't show up for work, like last week? And he's like, what? Oh, dude, maybe you're having another one of your episodes. But it was pretty funny though, because he just like strolls in, like he had like this, yeah, he didn't even have his shirt on at the time. He just strolls in and he's like, hey guys, like as if nothing had happened, and like he's just like thrashed. Like it looked like the cat had been him and the cat in a paper bag and just rolled around like blackberry slices. I mean, big old goose egg, and we're like, where have you been? He's like, and he's just like had no idea that he's late or anything. He's like, what? Where's my? Who am I relieving? We're like, nobody. We're not relieving anybody right now. We just need to figure out what are you doing right now. We don't even know what's going on. And so yeah, so he had this crazy amnesic event of things where it's like he doesn't remember a single thing, and it'd be interesting to have had a little GoPro on him the whole time just to maybe listen to the conversation he's having with himself, because he's that kind of person that, like, as he's over the embankment, I could just hear him going, what? Stupid idea, like how, and then when he all of a sudden realizes, what am I doing here? Oh, geez, oh, and then he gets up to the top and like, where do I go? I don't know where to go. It's one of those kinds of guys. But yeah, crazy amnesic effect after he hit his head and had a little Ambien mixed in.
At least he didn't get on Twitter.
Right, yeah, no Twitter, there wasn't Twitter back then. At least it wasn't popular. Okay, we already know about Cushing's reflex, right? Cushing's triad. We're good with that. We're good with recognizing that in our scenarios in the real world. Yeah?
Is it just increased BP, or is it increased BP with widening pulse pressures?
The big thing that you're going to see is you're going to see just a generalized increase in BP, because you're probably not going to have enough time with them to recognize a lot of widening pulse pressures. You're gonna pull up and you're gonna find a 120 over 180, and you're like, oh, hey, this guy's unconscious with a
120 over 180?
180 over 120. Sorry, wrong word, wrong place, obviously. So I figured you guys are smart enough.
Just making sure it wasn't like a trick
Some
vital
new-
here.
some
Some
new
new
vital
vital
sign
sign.
you guys?
Yeah.
No, it's gonna be one of those things where it's like you're gonna get a reading like that, and you will have done it on the monitor. What's the first thing you're thinking?
Monitor's
You
You
broken.
check it.
Yeah, you're like, oh, this is dumb, this guy's gotta have blood pressure of 70/30, right? Because this guy's unconscious from a trauma, right? So you hit the NIBP again, boop, comes back the same thing. Now what?
Feel it.
So now I'm still thinking that the monitor's broken, right?
Just feel his pulse, right?
So then so that's why it's good in these kinds of things, like in traumatic events, get the manual blood pressure to start off, because then that gives you an accurate baseline to start with, instead of having to, whoa, hey, whoa. Whew, that was close.
He's been working out.
So that's why it's really important to get that blood pressure manually, so you have the first one accurate every time. It's not a microwave, just so you know. You need to use it?
It's a television.
No, I need it up already.
Okay. And so, yeah, so you're not gonna really see a lot of trending. You'll probably get 2 pressures the whole time, because in a patient like this, what are you gonna be doing?
Transporting.
Doing everything
Intubating.
else.
You're doing
Intubating.
everything else, right?
Primary pressure, 2 IVs.
You're gonna be not getting the IV, you're gonna be
Not getting the
not
tube.
getting the tube. You're gonna be trying to figure out how to put a king tube in, but you didn't have that ready because you tried to intubate a couple times and you just missed it, so then you forgot to get your backup airway ready. And then you're gonna realize that they're bleeding out everywhere, and so now you're trying to figure out, oh, I got blood on me, I need another pair of gloves so I can do this. Oh, and next thing you know, now you're at the hospital.
And somebody vomited.
Right? Because that's how calls go when things don't go well, right? That's 100% how that happens, right? Like when you start to have things go bad,
Everything.
it just goes bad at worse and worse and worse. Did you guys hear about the pretty significant MDA night before last?
Was
Yeah.
it the one with the 16-year-old?
Yes.
They came into the OR during my shift, so we had a few people, anesthesiologists go and get pulled off for them.
Yeah. Anybody know people involved at all? You guys okay talking about it? Okay, alright. So once again, this is all confidentiality stuff. This is kind of a, no, and there it goes, you just Facebook Lived it, cool. Yeah, so 16-year-old, major trauma, major head injury, right? So it was my crew that, not my crew, when I say my crew, like the people on my crew are like my family, my crew, they're my firefighters. So that's my medic that was on the call and ended up getting this kid. So it's one of my probies and one of my, I call him my veteran firefighter. He's got like 2 years of experience, but he's one of my better firefighters. He's my go-to firefighter for all my truck work, stuff like that. But it's with one of my probies. I'm like, and he's not an FTEP, but I told him he has to babysit. And I'm like, all right, you gotta watch the probie. You gotta make sure he does everything right. So they get in the car, and you know how I told you how Raleigh did the whole, hey, palpating the scalp thing and into the brain thing? Well, they had another moment like that, where they get in the back, they go to grab the head, to open up the airway, holding the C-spine, they end up having to bag in the car. Like this is where we practice bagging in the car and doing all our stuff in the car for a reason. Person was trapped in the car and they had to manage the airway and do all that stuff in the airway. So I go up to grab the head, boom, hand basically, they weren't even palpating to palpate, but it was one of those, I'm holding C-spine, I'm holding it, and I'm, So they're trying to find a secure spot on the side of the head to be able to hold. And so this was the probie's first real big traumatic event call, right? And it's a kid, so awesome for him, right? No, not really. So long story short, they get the kid out. So they were up in the North Delta area, so they got transfer time of like 5 minutes.
So it's like 55 plus?
Yes, plus. And so it's like a 5-minute transport time. By the time they get the person out of the car, all they have is, they don't have the airway managed because the person was still breathing and all that, but they have the IV established, and so they go, what are they gonna do? What is your guys' thought process? Boom, person's on the backboard now.
That's what GCS.
What do you wanna do? GCS is like probably 7-6.
Try and get him in the back of the
Yeah,
bus
they're in the back
instead.
already. So boom, they come out, poof, they're on the backboard, they're in the back of the ambulance. Hey, how many riders you want? Hey, somebody send me.
So get
They
somebody,
didn't have enough, just so you know.
you got somebody bagging?
Yep, somebody's bagging.
Somebody's bagging, well, I've got my
Our side.
fentanyl,
Hey, what meds are
lidocaine.
you going with?
Fentanyl, lidocaine.
And
Faster,
etomidate,
dude.
Etomidate.
Person's dying right in front of you.
etomidate
Rock- or
sucks,
Socks.
fentanyl, Versed,
Yeah.
and then
Okay, so you gotta wait 3 minutes for the lidocaine, right?
Yeah, you don't have.
You only have
time.
Alright, so now
minutes.
you're down to 2 minutes to get to the hospital. Oh, son of a, so now you got 2 minutes to go, right? So yeah, so the awesome thing is they did an awesome job, they got all the drugs pushed in the appropriate time. They got all the drugs in and everything.
Did they have the IV established in the car?
They did, they got the IV, they had the IV, vital signs, and we're bagging them.
Pushing the stuff before they ever came out of the car.
They did not know, they did not push it before they came out of the car, because by the time they got the IV, right when they got the IV established, the kid was ready to come out of the car.
Were they intubated by the time they got to the hospital?
No,
Just the drugs were pushed.
The drugs were pushed,
Okay.
and they made multiple attempts to get the intubation. And what happened is every time they went in, their airway completely filled up with blood. And so they would suction, 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 they'd go in again, airway would fill up with blood instantly. So here's a little teaching point for you guys. So if you get in one of those situations where it is like that, where you get in there and there's nothing going on, take your Yankauer, stick it in there.
Ginkauer.
Your what?
Your fart suction device, Yankauer, Yonker,
Okay.
suction thing, right? So you go in there, you find what you're looking for, drop the Yankauer in there and slide it to the left and leave it there, okay? I know we talked about.
Like the dentist.
You're now a hygienist.
Yeah, you're not a dental hygienist, and you just leave it alone. The only way this works is if you have the Yankauer that doesn't have the hole involved. If it does have the hole, throw a piece of tape over the hole so it constantly suctions in order to get that, right? Because they're constantly filling up. I know we talked about don't do it very more than 15 to 30 seconds, depending on who you are, what you have, right? Just drop it in there and suction, right? Because now our whole job is to get that ET tube, right? You have paralyzed this person, the respiratory drive is gone, you have to secure this, right?